I'm going to talk to you about emergencies in space. And this is an interesting topic in the sense that so far, fortunately, it's all theoretical. Um, we haven't had very many actual medical conditions in space, and we've had very few medical emergencies in space. And you may think of some examples that we'll talk about with the Challenger and Columbia and things like that. But they weren't really emergencies in space. They were on launch and on reentry. I'm talking about what happens if you're living on Mars or on the International Space Station and you get sick or you have a heart attack or God forbid somebody goes into cardiac arrest or something like that. What do we do and how is it different than what we do here on Earth? And there are a number of challenges that come up. Firstly, because it's an austere environment. You're in a resource limited situation. You are far away from definitive care and you're entirely dependent on whatever you've got on board in terms of manpower, equipment, know-how, and expertise. And then microgravity does all sorts of interesting and weird things to human physiology and to medications as you want to administer them. So that's what we're going to talk about for the next hour. And hopefully it's some food for thought for folks, especially if you're interested in emergency medicine or critical care medicine, which is what my background is in. So quick disclosures, and we went over it. I'm the CEO and owner of Lightyear Medical. The views and opinions that I'm going to express here, and none of this is proprietary, are mine. They don't represent anybody else on a higher level. So NASA, any of the commercial companies, any of the other partner organizations from Canada, Europe, or Japan. And everything you can find that I'm going to present, you can find in the open literature. So we're going to talk about medical concerns, medical capabilities, and how that's changing because the mission going to space is also changing. And then some of the unique environmental considerations. And then I'm going to apply some of that, some hypothetical cases, but cases that aren't necessarily that far-fetched. Some of them having some anchoring in historical events. So who better to tell us what it's like living in space than astronauts themselves? So this is a quote from Megan MacArthur, who was the pilot on Crew 2. And she says that things that are very, very simple on Earth suddenly become really, really hard. Even something simple like sleeping or brushing your teeth, you have to really think about it. How am I going to do this successfully and without making a mess? And so you're going to see a bit of a theme come up here with some of the astronauts. And so this is from Doug Hurley, who flew on Demo 2. And the pilot, so he was the commander. The pilot for his mission was actually Bob Behnken, who was Megan MacArthur's husband. So they sat in the same capsule in the same position for both their missions, which is kind of cool. And if you want to talk about some kids that have got a lot of parental pressure, right, both mom and dad are astronauts and very successful ones. So what Doug Hurley said echoes what Megan said. People to a degree think that it's pretty glamorous to be able to go into space, but it's actually just a really messy camping trip. Again, you got to be careful what goes on up in space because you can make a mess, and you can make one fairly easily, and especially if you're not paying attention. So you cannot have an aerospace medicine lecture without this slide popping up somewhere, and it's very, very applicable now because of what we're doing. It used to be that you were very carefully selected from a large applicant pool, very carefully screened from a health perspective before you became an astronaut for one of these professional organizations, whether it was NASA, the European Space Agency, the Canadian Space Agency, JAXA. But that's changing. We are starting to have more and more commercial spaceflight opportunities where some of these folks are bringing in some baggage in terms of medical history. And we're not going to be sending the pristine human specimen. People who take no meds, have had no surgeries, have no health concerns, can run a sub 6 minute mile, things like that. We're going to be bringing in some people that are very wealthy. And so they're probably a little older. They've probably got the lifestyle of decadence behind them with right, some issues, high blood pressure, maybe some pre-diabetes. But what happens when you go to space is that you're suddenly entering a very abnormal environment. And traditionally what we've done is we've sent normal physiology. So you can see down here in the middle bottom row, that's what spaceflight has been traditionally. You've got normal physiology in an abnormal environment. but we are starting to move into abnormals across the board. We're going to have some abnormal physiology in an abnormal environment. So what happens, right, if I show you normal environment and abnormal physiology, you're looking at your ED patients, your ICU patients, and these are the folks that have medical emergencies and come into the hospital, and sometimes they get sicker. The disease course progresses and you end up running a code on them, and you have to deal with some pretty sick folks. So we are potentially going to have that same patient population starting to now exist in an abnormal environment. And how are we going to go about treating them, and what challenges go along with that? So this is something that I aspire to. This is a screen capture from this paper. How would you like to be able to write a paper where your abstract is 2 sentences? Right, that's dropped the mic level publication as far as I'm concerned. But I think it sums it up perfectly. And Smith Johnson is a very experienced NASA flight surgeon. He's now the chief medical officer for Axiom. And Tom Marshburn is currently the commander for Crew 3 and up on the International Space Station. And then Dave Williams is a former Canadian astronaut. But they sum it up perfectly. Manned spaceflight is inherently risky and results in unique problems from a trauma and medical perspective. Emergency care under these special physiologic and environmental conditions calls for novel techniques for diagnosis and therapy. And this paper then goes through to describe some of those, but I think it hammers the point home. Things are going to be different and they're going to be challenging. Our experience with spaceflight is still in its infancy, I would argue. Just recently with the launch of Crew 3, the 600th human launched into space, went into space. So we've got a very, very small end in terms of our research. And you can see that it starts from the 1960s and progresses into the 2000s. The Russians have been fairly stable in terms of what they've been sending. They've been sending the Soyuz from pretty much day one, and they continue to launch the Soyuz. But the American programs have changed, right? From Mercury, where it was 1 astronaut, to Gemini, where it was 2, Apollo, it was 3, the shuttle, where it was up to 7. And now we've gone the other way. We've left the shuttle behind, and we're coming back to capsules with Dragon, with SpaceX, and Boeing and Blue Origin are also flying capsules as well. So the evolution is still in progress, and we're going to learn some stuff as that evolution continues to progress. As I mentioned, we have had fatalities in spaceflight, but they haven't been true emergencies in space, in the sense that there's been very little that's actually happened in space, right? Apollo 1, the 3 astronauts on that died during a training exercise on the pad. So they weren't in space. They had a flash fire inside the capsule. The doors opened inwards, so the pressure inside the capsule exceeded atmospheric pressure. So you had a pressure differential, and they couldn't get the doors open because they were pulling into a high pressure environment. And those 3 astronauts perished as a result. Soyuz 11, we're going to talk about a little bit more here in a second. This was on re-entry in 1971, I believe. 3 astronauts had a gradual decompression due to a valve that was left open, and arrived either dead or with agonal vital signs. And you can find YouTube videos of the Russian medical team attempting to code these folks, doing CPR on the ground in Kazakhstan to try to resuscitate these individuals. Challenger was during launch in 1986, so they hadn't made it to space yet when that vehicle broke up. Columbia broke up on re-entry, and then Spaceship 2, which is the picture you see here in the bottom right corner, was our first commercial space accident. There were 2 pilots on board that. 1 survived and 1 perished as a result of that. But again, they weren't in space. They were at very high altitude, and they were attempting to do a test flight when that broke up. So in terms of actual emergencies in space, there really hasn't been a whole lot. This is a picture of Soyuz 11. So you can see the capsule came back and was in, excuse me, I got 2 dogs in the room here. The capsule came back and looked like it had a nominal re-entry and a nominal flight profile. And everybody was very surprised when they opened up the capsule and found 3 astronauts either without vital signs or in significant medical distress. And as I mentioned, all 3 of them perished as a result of that. We have had some potential cases. And so this is Richard Garriott. He was a space tourist that flew back in, I think it was 2008. He was the son of Owen Garriott, who was a space lab astronaut for NASA, or Skylab, sorry, astronaut for NASA. And he made a significant fortune in the comic book industry and bought a seat on the Soyuz to fly to the International Space Station for a period of time. During his workup, it was noted, and you can see the slice from a CT scan here, that he had a fairly large, it was 12 centimeter hematoma on his liver. It was asymptomatic. It was an incidental finding. He didn't know he had it until the workup for this. And he was also found to have a cross-fused kidney. Again, another incidental finding. What ended up happening was he wasn't deemed flight worthy from a medical perspective because of this hemangioma. So he underwent elective surgery to have this resected. And the concern was that this thing posed significant risk in the event of a trauma. So if something were to happen, either on launch or re-entry, a hard landing, or if something were to happen on the space station, that some object in microgravity developed a fair amount of velocity and impacted him on the side, and he started to bleed out, it was a risk. And so NASA likes to buy down risk, and that was what had to happen. And fortunately, he was working with a number of NASA flight surgeons, and so all this is published. And you can find this, it was published in the Aviation, Space, and Environmental Medicine journal. Now the aviation, I can't remember what it is now. It's what we call the Blue Journal, and it's the Journal of the Aerospace Medical Association. And so you can find all these cases written up. But he had it resected, had his mission, and it went well. Another gentleman who flew, Gregory Olson, flew in 2005, 57-year-old, and he's coming closer to what we're expecting to see in some of the commercial space individuals. So he had significant past medical history. And again, you can see that this was published in the Blue Journal as well. Excuse me, not COVID. You can see that he had a number of issues, and some of them are actually fairly scary when you think about the environment. He had COPD, and not only that, he had bullae, and he had a history of a pneumothorax. So if you have somebody who gets a little bit of a COPD exacerbation and ends up air trapping, and then you have a slight depressurization of the capsule, that trapped air is going to expand. And as it expands, it may rupture a bullae, which may cause another pneumothorax. And this actually came closer to happening than we potentially expected. And that's why aerospace medicine is risk management. His capsule actually depressurized down to 660 millimeters of mercury. So about 100 millimeters of mercury less than what is atmospheric pressure. So about a 15% decrease in pressure inside the capsule for a period of time during that re-entry. So the risk was there. And then he also had significant other findings that were potentially malignant in nature. He had some masses that were found, a renal cyst, and had a history of some ventricular and atrial ectopy during his workup and his cardiac monitoring. So we have sent some challenging medical issues into space. And so far it hasn't caused any major problems. But if we're going to start doing this more and more often, right, you're going to be accumulating some risk. And it's probably only a matter of time until you have some problems. In terms of the actual spaceflight environment, there are a number of concerns and a number of ways that spaceflight is actively trying to kill its participants and its astronauts. The International Space Station is actually a hypercarbic environment. It's about 3% carbon dioxide as compared to here on Earth, where it's about 0.3. So it's a 10-fold increase. And hypercarbia can cause some problems. And then airflow isn't what it is here on Earth, and ventilation becomes a challenge. So NASA has restrictions on how long people can work in a closed environment without some sort of fan to maintain airflow, to maintain ventilation. And there's a picture, I've got it later on in the slide, where we had 13 astronauts try to get a group picture. And it took long enough, and airflow was impeded enough that some of them were symptomatic from hypercarbia after the picture was taken. You get fluid shifts as a result of microgravity, increased rates of renal stones, which is probably a combination of some dehydration as well as some bone resorption as a result of the lack of stimulus that you get from gravity in 1G. You get right heart remodeling. There's significant radiation exposure, and there's a lot of debate in the literature as to what that radiation exposure means here in low Earth orbit, so on the International Space Station, or as we start going further and further out to the moon and eventually Mars. And one paper that I read suggests that in order to survive on Mars, the best thing we can do in terms of protecting our astronauts and our settlers from radiation is to have them live 12 feet underneath the Martian surface. Again, there's some debate about how severe this risk is, but nobody really knows is what it comes down to. Decompression risk, you are in a vacuum of space, so there is very little to no atmosphere, depending on if you're on a planetary surface or in free flight, and you're inside a capsule that's pressurized. So you can have a pretty big delta, and if you lose pressure, then you can have some problems as a result of that. Depending on how fast you lose pressure, you can have some really big problems. Thermal extremes from very hot and direct sunlight to very cold in the absence of sunlight. There have been thrombotic events, muscle mass, bone loss, infectious risk, and that's a big thing right now. COVID is still a thing. The ecless environment, so that's talking about hypercarbic again, trauma risk, right? You're traveling 17,500 miles per hour when you're on orbit, and to get back down to Earth, you have to bring that down to next to zero. And so that's a fair amount of energy that you now have to dissipate. And if you don't dissipate that well, then you're going to have somebody hit hard, or if one of the parachutes doesn't open on re-entry, you're going to have some folks that smack down pretty hard, and that can cause some problems. Toxic exposures, we'll talk about the gases here in a second that propel these rockets in the vacuum of space. Mental health and then reproductive health is the other thing that's going to become a challenge as we go deeper and deeper into space. So as I mentioned, some of the challenges, we've got limited events. We don't have a whole lot of data on what goes on in space because we've been sending primarily healthy people, and we've only been doing it for 60 years. We have mass and weight limits on what we can send up there. So you can't send a full ER trauma bay up there. You can't send a full OR. So what is most important, and what are you balancing in terms of determining what is most important for your medical equipment, your medical capability? Is it the high value, right? The cardiac arrest, is that it's the big concern, and when that happens, you want to be able to intervene upon it? Or are you going to start worrying about the things that are more likely to happen? Somebody's likely to get an infection or a laceration, so you need more antibiotics and wound care equipment, or is it a combination somewhere in between? And then what do you do with the stuff once you get it up there? If you look at anything in a hospital, you'll see that there's an expiration date and there's a shelf life for some of this stuff. So what you end up with is you need to be able to resupply these things, especially if you're not using them. And if we're going to go out to the moon or Mars or something like that, then it becomes even more difficult to do resupply. So do we have a way that we can create these items as we need them, and then resupply as we use them up or as they expired? There are various levels of medical expertise amongst the individuals that are making up a crew. You may have a doctor on board, as they currently do in Tom Marshburn. Tom Marshburn's a boarded emergency medicine and aerospace medicine doctor, but that's not always the case. Crew 1 and Crew 2 did not have a physician on board. They had a crew medical officer who received first aid and ACLS training and sutures and phlebotomy training on basic procedures like that. And there's a flight surgeon sitting console all the time in mission control that can guide somebody through doing a procedure, working up a diagnosis, and treating an acute event. But that becomes more and more challenging as you go deeper and deeper into space. Mars are expecting with our current level of technology that we're going to have a 20-minute delay in one direction. And so that can be a problem, right? Especially if you tell somebody to do something and they don't fully understand it. So you've sent them instructions, takes 20 minutes to get there. They have a question about it. It takes 20 minutes for that question to come back. You're really no further ahead. Limited expertise and training, we just talked about, the communication delays we just talked about, and then limited options for escalating level of care, right? You can't call for a transport to a higher level of care from your small standalone urgent care in the middle of nowhere, right? You are staying in that standalone urgent care that is the space station. So what you see here, the astronaut demographics, the astronaut population is starting to get a little bit older. And this is, you can see on the left, the ages. So the first groups of astronauts were all highly experienced, very healthy military test pilots, and predominantly male, actually all male. It wasn't until shuttle came around that we started having female astronauts. And we've had an increasing number of those since then. And I think that's a very good thing. in terms of diversity for spaceflight. But some of our early data is very heavily skewed to young, healthy white men, and that doesn't necessarily translate nicely to lessons that we can learn in other patient populations. But they are getting older, and that's what both of these slides are showing, and will probably continue to do so as we get more and more people into the astronaut corps and they get more and more experience. Right? Experience is a valuable thing, and so keeping somebody who's a little older around because they know what they're doing is beneficial to lots of operational aspects of the program. These are some of the medical events that we've had historically. Urosepsis and Fred Hayes in Apollo 13. There's a hypergolic exposure that some of you may not know about, and this was the Apollo-Soyuz test project in 1975. 3 astronauts actually spent 2 weeks in an ICU in Hawaii upon landing as a result of, and I'll show you the chest X-ray here in a second, as a result of an exposure. There was a liver toxin exposure in the drinking water on SDS-95, and this was significant because this is John Glenn's return to space. So we had a high-profile astronaut up there that had ingested water that tasted funny, was how the original reports came in. And that's how they found that this issue existed. We had a fire on Mir with a NASA astronaut on board in 1997. And there's debate as to how long that fire lasted for, whether it was a matter of seconds or whether fighting the fire took up to 20 minutes. And if you have a fire inside a closed environmental system, then that can be some challenges, right? If you depress or use a fire extinguisher, most fire extinguishers are CO or CO2, sorry. So you're now introducing more CO2 into an environment that already has more CO2 than people are used to. And now you're dependent on the scrubbers to clear that out after the fire, plus all the other issues that go along with fire, right? Carbon monoxide, cyanide, just soot and particulate matter in and of itself. We had a internal jugular DVT in 2019 that was fairly well publicized, published in JAMA. And then there have been a number of events with some cardiac arrhythmias being picked up on telemetry, including some of the early missions. So hypergols we talked about. For those of you that have done your pulmonary and your ICU rotations, there are 2 things in life that scare me. Pulmonary hypertension is one of them, because those patients, by the time I see them in the ER or in the ICU, are hanging on by a thread, and they tend to crash quickly and in dramatic fashion, and they can make for a very busy day. And so a terrible disease, I wouldn't wish it on anybody, and I never want to get it myself. The other thing that scares me are hypergols. And so hypergols are a fuel and an oxidizer that then spontaneously combust when they're mixed together. And the 2 that we use most commonly are MMH and NTO, so nitrogen tetroxide and monomethylhydrazine. And these are scary in the sense that you can see what the OSHA limits are. The OSHA limits for safe exposure for these things are basically 0. There are very few human reports on this because we can't do any research with it because they are that toxic, and they basically cause cancer in anybody who gets a significant exposure. It's just a matter of when, and the animal models bear that out. But this is what we're using as our fuels, and they work well in a vacuum, right, where you don't have oxygen as a fuel source. So you mix these 2 chemicals together and you get a spontaneous combustion. And what you want is a rocket engine that then makes this spontaneous combustion directed, and you go where you want to go. And if you don't have it directed, then you end up with what you saw on one of the pad tests that SpaceX did a couple of years ago, where the capsule blew up. And there's lots of video of that. Some stuff was leaked from mission control, and there were a lot of videos that were taken because there was a surfing competition going on when the capsule exploded. So this stuff is bad. It's a respiratory irritant, it's a mucosal irritant, and it's a known carcinogenic substance. So this is from the Apollo-Soyuz test project, one of the astronauts. This is their X-ray on the way up. So you can see how clear it was. These were healthy lungs in this particular astronaut. And then again, it's not a great depiction of the X-ray, but you can see that we're now starting to look like COVID lungs in the ones on the right. And this is after they had a significant exposure to hypergols inside the capsule during reentry. And you can down, if you type in Apollo Soyuz test project, you can get the medical report from that very easily off of Google. You can get the PDF of it and you can read through, and they've got their blood gases in there. And so they mainly went to the ICU for precautionary reasons. Nobody was intubated. There was very minimal supplementary oxygen requirements, if any, among these astronauts. But they could lock down the unit, they could maintain the astronauts' privacy, and they could monitor them closely. So they spent 2 weeks there recovering from this. What we have learned is that the vast majority of astronauts are using something on orbit from our medical kit. Up to 83% of crew members have used at least one medication. And the vast majority of them are what you would expect, right? If you and I spent 6 months somewhere, at some point I'm going to get a headache and I'm going to need Tylenol, or I'm going to have moved furniture item A from here to there and tweaked my back and I need some Motrin, or right, I need something to help me sleep, or I get a stomach bug and I need something to calm my stomach. And that's the vast majority of what we're seeing, right? It's motion sickness, headache, sleep disturbance, back pain, nasal congestion, constipation. And there are a number of different ways that they can take these medications. But what happens is we don't really know what the rate of onset is and the dosing for some of these medications. And there have been a couple of studies that have started to look into this. And this is, I think these are from the 1980s. These are shuttle era studies that looked at the pharmacokinetics of Tylenol. And some were quicker to reach that peak on the ground, or quicker to reach that peak on orbit. And so there were, you don't necessarily know what you're going to get in terms of how people are responding. And this is part of the reason for it. We talked about the fluid shifts. And one of the things, if you think back to your pharmacokinetics class, is volume of distribution suddenly becomes important. And so what happens when astronauts get on orbit is all the fluid, you can see the dark part. So we're going to start from the left and work our way over to the right. So you can see the density of fluid in the legs in the astronaut in terrestrial conditions. And that makes sense, right? You've had long days. I'm thinking of Shilpi, who's in the OR right now. If she were to send us a picture after she takes her socks off, I don't know what case she's in, but if she's in a long case and on her feet for the next 8 to 10 hours, bet when she takes her socks off, she's going to be able to see an indent from them, right? You get fluid that settles in your legs, and at night you put your feet up, you lay down, you wake up in the morning, and things are much better. When you go to space, that fluid shifts. And so what has previously been pulled down to your legs now redistributes equally. And you'll see facial puffiness or plethora in astronauts upon reaching orbit. And they complain of this. They say they get a headache, they get some sinus congestion, some nasal congestion as a result of it. And then they have a diuresis where they actually start losing some of the fluid because the baroreceptors in the carotid aren't used to that volume. And so it adjusts. And so you end up with some diuresis, and you end up a little hypovolemic. And about 70% of the astronauts, when they come back to Earth, are orthostatic and hypovolemic in some way, shape, or form. And that's despite an aggressive fluid loading protocol to try to get them back to terrestrial conditions before they come back to space. But if you've got fluid that's shifting around like this, then your pharmacokinetics are going to be affected as a result of that as well. So another thing that we see is fluid dynamics and microgravity are really cool. You can find YouTube videos of this, right? I pour water on the floor here. It forms a puddle on the floor and it'll splatter all over the place. I do the same thing in space where I squeeze liquid out of a can or a juice box. I end up with this big bubble that surface tension holds together, and it's just going to float around on its own and go where it will. As a unit, it's going to coalesce in that way. And that's a challenge for medications. And we'll talk about that in a second. Some people have a lot of fun with fluid dynamics and microgravity. If you don't know anything about Don Pettit, and this is him here, he was a 46-year-old when he was selected to be an astronaut, so the oldest astronaut ever selected. Don Pettit posts videos that indicate that he gets bored on orbit, which I think is incredible that he's able to get all his work done and still have time to mess around. And so one of the things that he did, and there are YouTube videos for this, you can find him explaining, and he'll do a better job than I do. He likes coffee, and I'm sure there are people in the audience right now that can go along with that, right? And the joy of drinking coffee is some of the aroma, right? You've got a coffee cup in your hand and it smells good. In space, you drink coffee out of a juice box, a Capri Sun type foil packet where you put a straw in and drink it that way. So you don't get the same aroma. And so Don Pettit used fluid dynamics and capillary reaction and surface tension to create a coffee cup that he could drink out of in space. And he started with just acetate overhead and tape. And now he's got a ceramic kiln that he's making of himself and using it to his advantage. But you also have problems with some of those fluid dynamics. So you can have a nice cup of coffee and you can use it to your advantage. Or if you end up with a big ball of fluid over your face, right, this individual is at risk of drowning in a puddle, basically. You can see that ball of fluid has entirely covered his nose and has covered his mouth. And so you may end up with some issues for that. So in this case, this guy just backs away from it and he doesn't have a problem. But what happens if it happens inside your spacesuit? And so we had two fairly significant issues with fluid in space. Chris Hadfield here on the left and Luca Parmitano on the right. So Chris Hadfield ended up with a tear. They used to use shampoo, baby soap to defog their visor or to make sure that it was anti-fog. He got some of it in his eyes, so his eyes started to water. And you can't crack the visor and just rub your eyes in the vacuum of space when you're out doing a spacewalk. So the tears just continued to build up and build up and build up, and he eventually went blind in one eye. Couldn't see out of it because he had a big ball of tears in front of the eye. And that was all well and good because, right, God gave him two eyes so he could still see out of the other side. But then that fluid ball got big enough that it crossed the bridge of his nose and then into his other eye. And so he's got a TED Talk where he talks about going blind in space and what that meant. So that was a challenge. Luca Parmitano had a bigger challenge where he ended up with a fluid leak in his spacesuit, and the fluid ended up filling up his helmet. And so now, so he almost drowned in space. So Chris went blind, Luca almost drowned. And so now they've got the snorkel. So if this ever happens again, there's a snorkel that the astronauts can put in their mouth inside their helmet, and it directs, so it'll start taking air from elsewhere in the suit, so you can get past a fluid bubble that builds up over your mouth or your nose. Same reason you can't open the spacesuit and readjust that fluid. So the crew medical officers I talked about, there are 2 per mission for every 5 to 7 astronauts. And the reason we have 2 is in case the one that is trained suddenly becomes the patient, then you've got redundancy in the system. You've got somebody else who's trained who can start caring for the sick patient, because you're not guaranteed to have a physician on board. Out of the last class of 10 astronauts that were selected last month, only one, Anil Menon, was a physician. So it's not a huge percentage. So you're not guaranteed that you're going to have one on board. As we go further and further out in space, I think you're going to see that we're going to need to have a doctor on board so you can have some autonomy, especially in the communication delays that we're expecting. But the training's reasonably minimal, right? It's not residency level. You're not training somebody up to be a physician. You're not even really training somebody up to be a paramedic or a medic. You're training them up to do first aid and to do as much as they can for what so far has been a fairly low frequency event, right? Some sort of medical event or emergency on board. It's going to change further as we go further and further out into space and we leave the ISS behind and we start traveling to planets and celestial bodies on the Orion. Right now, the ISS has 9 subpackets of medical equipment. And so they're about the size of a carry-on suitcase, each of these subpackets. Orion, we're going to have 1 because of size and weight and mass restraints inside a capsule. The ISS is fairly well stocked, and if you've got Michael Barrett's book, you can read through the entire list of the medical equipment that's on board the ISS, and it's 5 or 6 pages. We don't know what it's going to be for Orion, but what we do know is that it's going to be limited. The contents to be determined. There's a lot of discussion as to what needs to be in that one sub packet. And so you're going to have about a 85 to 90% reduction in what you're taking for this particular mission on board the capsule, right? You may be able to send other stuff on resupplies, but this is what you've got in the capsule with the crew during free flight. So we've got ways. So this is the crew restraint device that we're using, and we would use for codes and for medical assessments, because your patient's going to float away in microgravity. So you need to have a way to secure them to the ground or to something, to the structure, so that you can properly assess them, or do CPR if you have to. And you can see that's Tom Marshburn doing an ultrasound on Chris Hatfield, and he's on the crew restraint system. Crew medical restraint system there that's up on the ISS. So we've talked a lot about mass and weight and the challenges that go along with that. It is expensive to send a kilogram of mass to space. So on the shuttle is about $54,000. With the Falcon 9, it's down to about $3,000, but that's still a very expensive kilogram of stuff. And so the thing that immediately comes to mind when you start talking about a kilogram is that that's 1 liter of IV fluids. And if you or I got septic, we would need 3 liters of that just up front, right? I'm probably getting close to a 2,500 to 3,000 cc bolus if you're following early goal-directed therapy. That's a really expensive resuscitation just up front. And so the anticipated need for planetary exploration is that we're going to need about 100 liters of IV fluids. And so the device that you see here is called IV Gen, where there's a way that you can create IV fluids while you're up there. And it's not as simple as just taking the amount of sodium chloride that you would want and dropping it into sterile water and hoping it mixes up. Because in zero gravity, what you find is that you're going to get some areas that are going to be higher concentration, some areas inside that same IV bag that are going to be lower concentration, simply because of how fluid dynamics and things mix in microgravity. So that's why a machine like this is required. 3D printing is also, I think, going to become very important in terms of, can we 3D print as we require some sterile devices? Do I need to fly central lines and out lines and things like that? Or can I print them up with a 3D device and make them sterile? Can I impregnate that plastic with something that's antimicrobial? And then can I reuse that plastic when I'm done, right? So I'm done with my resuscitation. I've extubated my patient. I've taken the central line out. Can I reclaim that plastic, that polymer, sterilize it again, and put it back into the reservoir so that I can use it again if something were to happen to the next patient? Maybe the next patient needs a chest tube or something like that. And so I think we're going to see a lot of new developments that way in the near future. There's some companies that are working on this. And I think you're going to see some terrestrial applications that are going to be pretty impressive as a result of that, because suddenly some of the austere operations of the South Pole, things like that, resupplies become much easier as a result of that. So we're going to talk really quickly about 4 scenarios, and then I'll open up to questions. And these are the ones we're going to go through. We're going to go through decompression, arrhythmia, code blue, and then trauma, hemorrhage, transfusion. So we've had issues with DCS, Soyuz 11, Challenger, and Columbia. The autopsies of the Columbia astronauts demonstrated that they all had dysbarism and hypobaric injury on tissue samples on pathology. So we had more recently, we had loss of atmospheric pressure on Expedition 56. That's what this picture up at the top is. There was a hole that was drilled into the Soyuz, and it was into the service module of the Soyuz. So it was a part of the Soyuz that burned up on reentry to come back for a forensic analysis. But you can see it's a very intentional hole. You can see where the drill bit skipped. And so the Russians have done an investigation. They've made some conclusions, but I haven't heard exactly what it was. But this was detected because people on the ground were noticing that there was a loss of pressure in various segments of the ISS. So they pressure locked various segments and did a search until they isolated where the leak was. And then they did a hard target search inside that segment to identify this very small hole. If we were to have somebody that had developed the bends, decompression sickness as a result of that, then there is some theoretical evidence. Mike Green's the author, and it's in the Blue Journal as well, where we talk about using the suit, the EVA suit, as a pressure vessel in a small hyperbaric chamber, and you can crush the bubble. You can overpressurize it. You would then decommission the suit, and it would no longer be certified for EVA, but you would provided medical care and treated the astronaut as a result of that. Yeah, so arrhythmias have also come up. It's a relatively common event on EVA, extravehicular activity, or a spacewalk. And you can, with that crew restraint medical support system that I showed you, that device, it's actually electrically isolated. So you could defibrillate an astronaut that ended up in VTAC and VFib as a result of that. And we talked about the diuresis that goes along with being on orbit. So things like electrolyte abnormalities are potential concerns, especially if you've got somebody that's diuresing and not feeling well and having some nausea and vomiting, space adaptation, motion sickness being what it is. You may end up with somebody that ends up hypokalemic or hypocalcemic as a result of that. And so then if you give them something to treat their nausea, their vomiting, their GI upset, right? Zofran is a QT prolonging agent. So if they've already got a little bit of QT prolongation, you give them a medicine that makes it worse, then you may end up with somebody that ends up in torsades and needs to be cardioverted. And so we do have that capability up on the space station. And this is an actual rhythm strip from an astronaut during an EVA. You can see, and this is actually counting as a sustained episode of VTAC. I think it's 13 or 14 beats that you're seeing there. So if that astronaut, right, does develop VTAC, VFib, and you end up having a code blue on space or on orbit, then you've got some challenges. You can see here, so this is Sunny Williams running on the treadmill, that Newton's third law becomes very, very important. You can see that she's got a belt and a shoulder harness, and she's restrained down to that treadmill, because every time she pushes off with her foot, there's no gravity to bring her back down to space. So for every force, there's an equal and opposite reaction. And so if she pushed off with her foot, she would just float into the ceiling without that restraint system bringing her back. So you need to come up with a way to restrain your patients. I showed you the fluid dynamics of what surface tension does. And so when you ask your pharmacist to drop a med during a code on Earth, they're able just to put the syringe into the vial of medicines. They're able to flip the vial upside down. All the fluid comes down real close to the needle. You drop your meds and you're off to the races. In space, that doesn't happen. You're going to get a ball of fluid somewhere inside that vial, and you may have to do some gymnastics with that needle to get it into that pocket of fluid and suck it up. And the other thing that happens, and this is what IV fluids on orbit looks like, you can see that bubble of air that we have inside all our IV fluid bags here on Earth, that, right, we hang the bag of fluids, the air goes to the top and it's not an issue. The air is mixed in with the fluids here, and you've got a lot of bubbles. So you can maybe get some of the bubbles out by centrifuging it. So if you grab hold of the bag of fluid and just swing your arm around in a circle fast and hard and for long enough, then maybe you can get all those bubbles out into one big bubble. More than likely, what you're going to have to do is you're going to have to put a filter. You're going to put an air filter on your IV line to run that bag of fluid in. And when you put a filter on, then you've limited the rate at which you can run your bag of fluid. So you're not going to run it at the ED 999 wide open as fast as you can bolus for resuscitation. So you're going to have some limitations from that as well. This is what CPR in space looks like, and there are multiple techniques, but these are probably the best two based off of some theoretical data from microgravity flights, the zero-G flights, the Vomit Comet, the handstand method, which you see here in the middle, and then it's the Evitz-Russomanno, the ER technique, where you actually, so that astronaut has got her right leg over top of the, her left leg over top of the right shoulder of the astronaut, and then her right leg is hooked underneath around the astronaut's midsection. And she's using her legs to stabilize the patient and apply chest thrusts that way. So what you would probably see is a combination of these two, right? People aren't going to code nicely on that bench that you've got them secured on. So somebody may start CPR with the ER technique as you move the patient towards the CRMS and strap them in, so then you can do the handstand technique. The handstand technique does get you some better depth, but again, it's limited, right? If you have a smaller astronaut in physical stature, their feet may not necessarily reach the ceiling where their hands extended fully above their head can then reach the chest of the patient. The other thing to keep in mind is if you've ever been part of a code teams are large. And if you've got 6 astronauts on board the International Space Station and one of them codes, you've now got a 5-person code team. And so somebody has to be drawing up the meds, somebody has to be doing CPR, somebody has to be managing the airway. You're very quickly going to run out of hands for all the tasks that you have. And then you're coding a friend, right? You're coding somebody that you are working and living with. And there's a fair amount of psychological stress that goes along with that. And I can remember my first code as a med student. It was not fun, and I didn't know the patient at all. The patient didn't survive, and I remember feeling bad about that. Right, that was somebody that just died, and I was there to witness it and wasn't able to help them. So what happens when it's your friend and somebody that you worked with and maybe had for years that you just coded and weren't able to save? There's a fair amount of psychological harm that is potential in that situation. But say you are successful and you get them back, so now it's time to intubate the patient and have post-arrest care. So it's challenging to intubate somebody in space. That's another benefit of that restraint system, because if you put the laryngoscope blade in and then start lifting for the ceiling, right? The anesthesiologist, are they still telling you to lift for the corner, right? Lift up and forward with the blade. The patient, if they're not restrained, they're just going to go along with you. And so you're never going to be able to get that view. Because the CO2 environment on the space station is as high as it is, colorimetric CO2 detectors are unreliable. And so what you end up doing is they use this bulb detector that you see here. And if you you squeeze the bulb and put air into the ET tube, and then you let go. And if the ET tube is in the trachea where it's supposed to be, then that bulb's going to fill back up because you've pumped air into an air-filled space, and some air is going to return and you're not going to get suction. But if you've put the ET tube into the esophagus and you press down and push air down that tube and then let go of the bulb's not going to re-expand because that air has gone down to the stomach and it's hopefully not coming back up. And that suction is going to be maintained. And then, so the other issues, we talked about the crew size, the challenges with CPR with that. But now you've got a patient that you have to manage in an ICU type environment. So you have to be able to sedate them. You may have to paralyze them. They may not be synchronous with the vent. And so you may have some challenges that way. How do you prone somebody in space? In microgravity, right? You have to spin them really fast to get any sort of gravitational force. So proning, it's something that we do here, and we've been doing it a lot, especially during the COVID pandemic. But you can't prone somebody in microgravity. You can't invert them. You can't evert them. Right? There is no gravitational force to make those things an actual thing. And then how do you ventilate somebody who's already in a hypercarbic environment? And so for certain conditions, right, we know that hyper and hypoventilation, especially brain bleeds, things like that, you can have some challenges in terms of your cerebral perfusion and blood flow elsewhere. The lungs also respond. CO2 is a very vasoactive substance. So this is the picture that I talked about earlier. This is 14, I think it's 14 astronauts. And it took them a little while to get this selfie. But it's a cool selfie, and it demonstrates that there is no up, there is no down, right? Any one of these folks could think that they were standing on the floor and the other folks were hanging from the ceiling. But they ended up with a number of them having nausea and vomiting as a result of CO2, just from the amount of time it took to pose for this picture. If you do have somebody like Richard Garriott that ends up with abdominal trauma and shock, then you're going to work them up to try to figure out where here on Earth with somebody that's got blunt trauma and suspected intraperitoneal hemorrhages, we do a FAST exam. And those are images from a FAST exam. These are actually, it was Peggy Whitson's liver, kidney, and spleen that you see there. And this was published in the Journal of Trauma and Acute Care Medicine. But it's dependent on gravity, right? You're dependent on gravity for that blood to show up in the dependent space and you'd be able to detect it on ultrasound. And you don't have that luxury in space. So you may end up with fluid pockets and a positive FAST that if you're trying to interpret it as being a terrestrial environment, you may miss the positive findings on the FAST. because we don't really necessarily know exactly where it's going to collect inside the peritoneal cavity. We do know that it's probably going to collect somewhere because of surface tension being what it is, but these 4 views may not be adequate to find that. And if you do find where they're bleeding, and you want to resuscitate them, then one of the ways, if you're losing blood and you want to give somebody something to make them less hypotensive and less tachycardic and less shocky, you're eventually going to have to give them blood. And so if you're going to do that, then you're going to do similar to what the military has done in some situations, where the people on your team become your walking blood bank. And so are you going to factor in blood types into your crew selection, your astronaut selection, your crew selection training? And there's a paper that discusses that. And you can see, right, are we going to send somebody A, B, and a couple of universal donors? Are we going to send paired blood groups? So 2 people are AA and 2 people are BB, or are we just going to send a single blood group? So all O's or all A's or all B's or some combination thereof. And the reason you're sending 2 of the universal donors in the first situation is in case the universal donor becomes the patient and needs to get blood transfusion from somewhere else. So there is another donor that can then provide them with blood. So in conclusion, medical emergencies in space are going to be challenging. And if you're geeky and nerdy like I am, then they're a lot of fun to think about. And there's a lot of intricacies in the microgravity and the aerospace environment that make them an interesting thought process to go down and to chase. In order to plan for what we're going to do, you've got to have a pretty good working knowledge of human physiology and then the microgravity environment and how those 2 interact with each other, and what type of emergency you're thinking of. I think it's fairly clear that exploration class missions are going to need to have a physician on board, because it's not an if in that situation. If we're going to send a large population to live for a prolonged period of time in space, you're going to have a medical emergency, and you're not going to want to rely on the communication delays. You're going to want to have autonomy and the ability to deal with these issues. And I think all of this is challenging, but it's going to lead to a number of new advances in technology that we're then going to be able to apply to medical emergencies and medical care here on Earth, especially in austere and resource limited environments. So with that, thank you very much. Hopefully this was interesting, and I'm looking forward to hearing some questions.
That was a really cool talk. Thank you. So everyone, you can put your questions in the chat or, ask them out loud if you'd like to. I'll start off with some of the questions we've got here. First one is there a risk of aspiration when eating, drinking, brushing teeth, and similarly like GERD? Is that kind of an issue for microaspiration and low gravity?
Yeah, and so there are a couple of interesting cases that go along with this. So I've got a friend who's got achalasia, and he ended up with a sphincterotomy. And so what the surgeon told him was, right, I'll do this procedure, it's going to fix you, your quality of life's going to get much better, but you're never going to be allowed to be an astronaut, because, right, you no longer have a sphincter, you now have a tube. So whatever goes down into your stomach, if you're not in gravity, it's going to go somewhere in that tube system. Not a problem for him, right? He has zero interest in being an astronaut, but just, I think the surgeon thought it was really cool that he could consent somebody, and one of the things on his consent form was you can never be an astronaut. But that is a risk that you worry about. There are stories or case reports of astronauts having something end up in their airways somewhere, because anything that ends up, if you cut something off or a crumb floats away or an M&M or something like that, it's just going to go until it finds a place to settle. And so the air vents in the space station, I hear, are somewhat disgusting, and also a very good lost and found, because that's where things will eventually circulate to. But Mike Barrett presents a case report, if you ever have a chance to have him present some space medicine stuff, where he does an aspiration case where it's to the left upper lobe, because here on Earth, you worry that if somebody aspirates, it's going to the right lower lobe, right? It's going to go to the most dependent spot, and it's going to follow the straightest tube on down. But that's not what's going to happen in space. You can have somebody aspirate something, and it can end up in the upper lobes, it can end up in the middle lobe, the lower lobe. Yeah. very different.
That's really interesting.
You say, could you repeat his name one more time?
Yep, Mike Barrett. So he's an astronaut physician. He is, if you're interested in aerospace medicine, he is a great mentor to young folks. And his book is Principles of Clinical Medicine for Spaceflight. And they just came out with the 5th edition, or the 2nd edition, sorry. I'm looking at Davis. The 2nd edition came out a couple of years ago. And it's got everything. It is the book for space medicine. And he's at conferences. He goes to the Aerospace Medical Association conference every year. If you are interested, the University of Texas Medical Branch has got a Principles of Aerospace Medicine course that they offer every July. You can apply to go to, and he comes and presents there, and does sort of like a stump the chump medical case review, where he gives you a scenario and then lets you work through it. And that's one of the ones that he has, is aspiration to an upper lobe, because that's how it may present in space. And I think it was something gross like a toenail. But right, if you're not careful clipping your toenails in space, that stuff's going to float away and somebody's going to find it.
Yeah. All right. I'll pass it to Nate. I see you got your hand raised.
Dr. Harrison, thank you so much for that presentation. That was the highlight of my Thursday by far.
Thank you.
I'm wondering if you had to choose one medical issue that you think presents like the biggest challenge for future planned manned trips to Mars, what would you expect that to be?
So I'm nervous about the radiation, but I'm going to be honest with you. I'm not a radiation physician. I don't fully understand it. And Jeff Chancellor, if you want to look up space radiation papers, Jeff Chancellor out of Louisiana is the gentleman that's publishing a lot of stuff and is the expert. But I'm worried about the radiation risk for a number of challenges. Right, what we may end up with worst case scenario, getting astronauts to Mars that then have significant cataracts. They have a GI cancer of some sort that then leads to massive hemorrhage or other challenges. Or if we're truly interested in becoming a multi-planetary species, reproductive organs don't like radiation. And so what happens as a result of that? And our efforts to shield are challenging too. Right, the ways that we generally shield radiation here on Earth is lead, water, or cement, all of which are very heavy. And so to get them off of the Earth's surface and onto orbit and into deep space would be very, very expensive from an energy perspective.
Yeah, that's really interesting. Thanks for that answer. I had a question about, are there thoughts of using things like a Lucas or an AutoPulse for CPR in space, or is kind of the weight cost too high with those to make it easier to do CPR?
So I asked this question 2 years ago when I did the short course at Texas, that are we going to send a Lucas or something like that? And the answer was no, because at the time, exactly what you just mentioned, weight was an issue. So you were going to send something up that had a certain amount of mass associated with it, then had a power requirement in order to operate for what was a low probability event. Right, the vast majority of the astronauts that are going up right now are between 45 and 55. They're in very good health. So you're not expecting somebody to have cardiac arrest up there with the current astronaut population. That might change, right? If we're going to start sending some older folks who have coronary artery disease, and some of the commercial astronauts that are going to be launching over the next couple of years that are already confirmed for some of these companies, we know that they have coronary artery disease. And so maybe then the risk profile changes. And things might change with the commercial space organizations too, because right, they're providing a service to customers and you've got to manage that particular group's risk profile. So maybe for the NASA astronaut, sending a Lucas is not feasible, and it's not, the risk benefit just isn't there. But maybe if you know that you've got somebody who's got coronary artery disease, you send a Lucas. Or maybe you don't. Maybe you do the triage in an austere environment situation where you've got somebody that now has an event that maybe you're just not going to be able to fix with your current set of capabilities and equipment. And so maybe, right, say you resuscitate them and you get them back with CPR, do you have the ICU level care that you need to for post-resuscitation care, or the ability to intervene upon it, right? That they threw a plaque and they had a STEMI, but I can't get them to a cath lab. And do I want to pump them full of TPA to then bring them back to earth? Yeah, there are a lot of questions that go along with that.
Yeah, it's almost like a start triage scenario of
right
resources sparingly.
And how far down the rabbit hole do you want to go, right? You can get them back, but then what do you do with them? It's the dog chasing the car, right? Once you catch it, now what?
Yeah. All right. See a few more questions. We had one about training. I think you covered that, and you talked about it's like 45 hours or 70 hours for the medical officer. Is there any other medical training for the other crew members?
A little bit. They do basic first aid and stuff like that, but it's minimal, and it's. I don't mean this in a derogatory way, but it's sort of an afterthought, and it's an afterthought because it's a low risk group that's being sent up there, and they've got a lot of other responsibilities. If you look at the schedules for the astronauts who are going to the ISS, they're incredibly detailed and really far out. They can tell you what they're doing 5 months in on a Tuesday at 10 a.m. because they know what experiment they're supposed to be working on or what maintenance activity they're supposed to be doing that far out.
Yeah,
they're busy.
All right, last two questions. One about whether in CPR they're using compressions only or actually using defibrillators. I think you mentioned defibrillators are used, right?
They have them. The challenge is you have to have a rhythm that's amenable to defibrillation. It's not like TV where everybody gets the paddles and the shock and they wake up and they're like, I saw Grandpa, but he told me it's not my time and I should come back. There are a lot of the number of times that you get to use a defibrillator in a hospital. It's less than 50-50 for the codes that I go to, right? A lot of times it's asystole or PEA that you're showing up for, and those, they're not shockable rhythms.
Yeah, good point. We have a question from Roy Dunlap about how do you compensate for no activation of the otoliths and proprioception issues?
And so that's a challenge for the astronauts. A fairly high proportion of them get what's called space adaptation sickness, where you get up there and it's worse in high volume environments. So if you're in a big wide open space, suddenly not having an up and a down or a left or a right, and you may suddenly get it all sorted out. You're like, all right, I know which way's up and I know which way's down. And then you watch a crew member go by in a completely different orientation, right? They've picked a different up and down than what you've picked. That is very provocative. And they say that some of the astronauts say that they don't get motion sick. And some of these folks are high performance fighter pilots that are used to high G environments and very challenging G forces. They still get sick up there and they don't feel well. And then they get the opposite. So that happens for the first 3 to 7 days on reaching orbit. And then they get used to it. And then they come back. And when they come back, now all of a sudden the otoliths start responding the way that they were used to, but haven't been doing that for the last 6 months. So if you watch some of the astronauts when they come back, they won't turn their heads. And you can find this, if you go look at some of the Soyuz landing videos, they don't turn their heads. You'll see them, they'll dart their eyes to the side, or maybe they'll turn at the hips if there's somebody behind them talking to them over their shoulder, but they're really careful. They do not want to do a really quick head movement. And it's challenging getting some of these folks out of their spacesuits, because some of the spacesuits come up and over top of the body and over the head, and that head forward movement that you have to do to get some of the suits off and the helmets off are really provocative. And for some of these companies, the rule is if you make the astronaut throw up inside the suit, you get to clean the suit. So everybody's motivated to make sure that they don't get sick. The treatment generally is Phenergan. Phenergan is the medication that seems to work the best for this, but it's also sedating. And so there are some challenges with that, right? You don't want the pilot of your capsule to be taking a sedating medication and coming back that way.
Thanks for the answer. Yeah, that's really cool. All right, last two questions, and then we'll go ahead and call it a night. Can you just talk about the modeling of and scenarios, simulation of space medicine scenarios that might happen? And then the final question is there any kind of leg up for being a military flight surgeon versus a civilian doc?
Yeah. So there is a medical model that they use, and I'm drawing a blank on the gentleman's name. Kurtzman, Eric Kurtzman, is the guy at NASA. So if you Google his name, spelled Kerstman, you will find the medical model system that he's using to develop what the medical capabilities are for the ISS. And it's being revised so that we can then figure out what we need to send for Orion. And it's based off of probability, what you can treat, what medications overlap, right? If I can send one medication that I can use to treat 4 different conditions, then maybe it's beneficial to send the second line agent that then has a lot of flexibility, as opposed to sending 4 first line agents for 4 different conditions that maybe I won't use any of them, or maybe I'll just use 1 or 2. So Eric Kurtzman's stuff, his publications are the ones to look at. And he usually has something published fairly regularly, at least in abstract form, for the Blue Journal and the annual conference. And if you end up doing, NASA's got clerkships for med students and residents. If you end up doing that, he's usually one of the folks that's assigning projects, and it's usually related to this this topic. In terms of becoming an astronaut, so the odds of not astronaut, it's flight surgeon. Does being a military flight surgeon have a greater chance? I don't know the answer to that off the top of my head. There aren't a whole lot of aerospace medicine training programs for civilians that are out there. The University of Texas Medical Branch, who's affiliated with NASA, and they get some of their funding from NASA. And generally the folks that come out of that program end up with NASA in some way, shape, or form. It's a feeder to them. That seems to be the biggest draw for NASA to be getting their flight surgeons. They do have some that they've picked up later in their careers that have spent time as a military flight surgeon in some way, shape, or form, that have now transitioned to the civilian side of the world. I don't know for sure if they have any active duty military flight surgeons as NASA flight surgeons. I don't think that they do. I think they're all either contractors through KBR, used to be called Wiley, or they're direct civil servants to NASA.
All right, very cool. Well, that was a really cool talk. Like I said, we've done a couple space medicine lectures, but this was definitely a special one. I really liked it, and some great questions. So thanks everyone for participating. I'll see you guys next week. We got that BWLS certification course through Survival Meds. You can look out for the registration email on that. Fill out the application if you're interested in applying for the board, and you can help us run these lectures for the next year. And thanks again, Dr. Harrison. That was awesome.
Oh, my pleasure. Thanks, Alex. Thanks for the invitation. And email addresses are up there, so if you have any questions that come up, don't be shy.
All right, y'all.